Hello everyone, my name is Dr. Prateek Joshi and I'm an orthopedic surgeon working at BJ Government Medical College and Sassoon General Hospitals in Pune. And this is the first video in collaboration with Medusane India. So thank you to Medusane and Team Medusane for giving me the opportunity to collaborate with you. So without any further ado, let us start off with this topic, which is the first in the series, that is case history and examination pro forma in orthopedics. Now, at an undergraduate level, most of us are familiar with the case-taking proforma in medicine, surgery, obs, gynae, or pediatrics. Whereas in case of orthopedics, the entire case-taking scene remains a mystery to most of us. And hopefully, by the end of this video, we will have sorted out the entire mystery and put in place a proforma by which you can get maximum information in the minimum possible time. So before we start, most of these slides are likely to be slightly theoretical with a lot of text on one slide, but this is the entire proforma which I have perfected over the years, and I'm putting it out here free of cost on open source. So please feel free to screenshot it or copy it or share the entire video to your friends and put it across if you like it. So starting with a couple of general principles. Now, why is orthopedic case taking a little different as compared to general surgical or for that matter medicine or OBGY case taking? That is because firstly it revolves around a history of a trauma. Most cases, some of them are insidious onset cases which we will talk about later, but vast majority of post-traumatic cases will start with an acute history of trauma. So patient was apparently all right till some time ago when patient suffered some kind of a trauma. This is what your starting of your history will be. Secondly, it is possible to create a very stratified and point-based history in case of orthopedics. If by the end of this video we shall have a 20-point history starting from the name of the patient all the way to the diagnosis at the end of examination, and if you cover these 20 points in sequence, you will be pretty much sorted for your entire case. So apart from that, orthopedics case history is about purposefully moving from one point to another, and not just from one point to another but towards the diagnosis which you are trying to prove. Now, in case of any other case history, this is a very prolonged and protracted process, whereas in case of orthopedics it is possible to quickly jump from one point to another without beating around the bush and getting to your diagnosis. Apart from that, marks obtained are directly proportional to how much ground you cover. Now let me explain this particular point, and that is that in any orthopedic case history, or for that matter in any short case, it is all about time. It is all about how much information you can get in that short amount of time which you are given to take the case, and more importantly, how much information can you put out in front of the examiner in those 5 or 7 or 10 minutes which are allotted for the discussion of the case. And therefore it is about ground covered per unit time, and therefore the which is basically your velocity. So the faster you move and the more methodically you move, the faster you will score points, because the more ground you will cover. So you will cover more ground and you will cover more points in a case where you are, say, at the end of examination at the 7th minute, leaving yourself 3 to 4 minutes of discussion based on theoretical topic, as compared to someone who has barely reached his negative history and is just about to start examination at the same time. And therefore what we need over here is adherence to a particular format. So format adherence is the key to success in any short case, and therefore let us create a basic proforma which you can follow to take your orthopedic short case. So first we start with the vital information. Now please note there are these little numbers in brackets here, and those are the points. So under vital information we will cover 4 points. Under chief complaints we will cover 3 points. Under negative history we will cover 5 points. Under past history we will cover another 4 points, and that will lead us to our differential diagnosis on history. Now something that I want to point out here is that differential diagnosis on history is a differential diagnosis made based on the data given to you by the patient, and therefore up till you get this particular point in the back, that is differential diagnosis on history is done, you have to use layman terminology, which means that you have to use words such as primary treatment was given or some sort of surgery was done. You cannot directly say that the patient was given an external fixator or an Elizaro ring fixator, because no patient is going to walk up to you and tell you that I have been given an external fixator. So history and history taking is all about collating data given to you by the patient. Moving on, you will have your next section, which is examination section, followed by which of course we will come to the final diagnosis. Now if you have a set of diagnosis, then it's always safer to quote 2 or 3 final differential diagnosis. Whereas if your case is extremely straightforward, such as an external fixator or an arrow, it is quite safe to give a direct final diagnosis. So starting with the vital information, now every time we ask for some sort of an information from the patient, you may be asked in your viva as to why it is important in that particular case. Now it is very important to answer coherently, which means that if you are in a medicine viva and you are asked what is the name of the patient, or if you are in a pediatric viva you are asked, then it is important to say that it helps you build a rapport with the patient, and it helps you come to a first name basis with the patient. It makes the patient comfortable, so on and so forth. No doubt these things are important in orthopedics, but when you are answering an orthopedics viva, it is important to also quote something which is specific to orthopedics. And that is why now when you have post-traumatic cases, vast majority of orthopedic trauma is a severe injury, or it is a grievous injury, and therefore most of these will snowball into medico legal cases, and therefore patient identification with a complete full name is very important for medico legal point of view, and that is something which you must mention when you are asked what is the importance of name in orthopedics. Also, moving on to age, now as we know, younger patients who are fitter like you and me are basically more prone to have a high energy trauma. When they have a high energy trauma, they will be susceptible not just to a fracture but to the soft tissue complications of high energy trauma, such as compartment syndrome, compound fractures, fat embolism, so on and so forth. Also, younger patients are more likely to be involved in high energy polytrauma as compared to old patients. Old patients are more likely to be involved in a trauma in a domestic setting, such as your falls at home or something like that. Also, in case of elderly patients, you have to think about age related comorbidities such as osteoporosis, osteoarthritis, diabetes mellitus, hypertension, so on and so forth. On the other end of the spectrum, you have pediatric trauma. So in any patient with a skeleton which is immature, that is before the fusion of epiphyses, we must think about epiphyseal injury, we must think about growth plate injuries, and more importantly, we must also think about medico legal aspects about all these things, such as battered baby syndrome and pediatric assault. Moving on, after name and age, what we have is the sex. There are a lot of conditions, especially in cold orthopedics, such as neoplasia and congenital conditions, which have a specific gender prevalence, in which case knowing the gender of the patient makes a difference. Also, gender related comorbidities such as estrogen being protective in the patients before menopause, and then postmenopausal osteoporosis setting in patients after the age of 45 or 50 is something which we must take into account, and that is the importance of sex in case of the vital information for the patient. Also, we must know about the occupation and the residence of the patient. In case of occupation, there are some occupations which are at a higher risk for high energy trauma, such as you have your roadside workers, you have workers in a construction or in an industrial setting. Similarly, for residents, now if you were in a pediatric age group patient, you could talk about something like hemoglobinopathies or something like that. But in case of orthopedics, apart from all these things, it is also important to note that for medico legal purposes, the residential address of the patient is as important for patient identification as is the name of the patient, and therefore it is important to know it. So we have our 5 points in vital information. Now moving on to chief complaints. So in the case of chief complaints, now this is one sentence which has to be at the start of your chief complaints. So if you use these 2 points in chief complaints, first is that patient was apparently all right n number of days ago when he suffered the nature of the trauma. It could be a road traffic accident, it could be an assault, or it could be a fall from height. Most of orthopedic trauma will fall into one of these 3 categories. So the person suffered an accident at state the place and state the time. Now this is important from different points of view. We'll get to this in some time. So whatever we say after this particular sentence is an offshoot of this sentence. So this is the first sentence in case of chief complaints. So the patient was apparently all right so many days ago when he suffered a road traffic accident at this place at this time, and the patient complained of. And I draw your attention to the 4 points underneath. First in sequence is patient complains of trauma to a particular limb. So you have to state the limb and you have to state the side. Followed by that, the immediate reaction after trauma is pain, and that should be your immediate next point, and that is pain to the given limb. Third would be an inability to use the said limb, which means in case of an upper limb trauma, it would be that the patient could not move his particular hand or forearm. In case of lower limb, it will be that the patient is unable to stand or unable to walk. If there is a wound, it has to be described, and if it has to be described, it has to be described in colloquial terminology, which means the patient suffered a wound which was the size of his thumb or the size of his palm. We cannot say 5 centimeter by 4 centimeter because this is something which the patient is describing in retrospect. So trauma, pain, inability to use the limb, and a wound. Next point is that what happened to the patient immediately after this trauma happened. Either the patient was lying there, or the patient walked to a primary healthcare center, or the patient was carried to a nearby hospital. This is quite important because the patient being carried or the patient being unable to walk is an indicator of a high energy trauma, and therefore we have to specify how exactly the patient reached the hospital. If there is a period of unconsciousness, we should mention it right here. Apart from that, primary treatment was given at a particular hospital, followed by which the patient was referred to your center, or if the patient was directly brought to your center, we can mention like that. Moving on, third is we have a negative history. Now once these 2 points are covered, we have 5 points for negative history, which will rule out pretty much everything. First point is head, chest or abdomen trauma. We ask this to rule out polytrauma, to rule out concealed hemorrhage, and to rule out any other further comorbidities. In case of the present head, chest or abdo trauma, the aim of treatment may change from early total care to damage control orthopedics, in which case we would have to apply a provisional fixation or provisional stabilization to ensure there is no further damage, after which the patient will be stabilized for another major surgery. So this is the importance of head, chest, abdominal trauma. Next, a specific group of symptoms, that is vomiting, convulsions and loss of consciousness. These three are grouped together because all of them point towards raised intracranial tension, which could be an indicator of a head injury. Third is ear, nose or mouth bleeding. This again will give us an idea of whether the patient has suffered any further craniofacial trauma. Craniofacial trauma is not only associated with increased morbidity and mortality, but also it can be associated with trauma to the cervical spine, which lies in close proximity, and therefore it is important to rule out all these things. Now we have to ask for the history of black eye or a red eye. Red eye can again talk about trauma to the orbit, and black eye can talk about base of the brain hemorrhage or base of the skull. Moving on, one set of history which has to be taken is diabetes, hypertension, asthma and tuberculosis. This will not only cause a problem in future wound healing, but also it can be a further confounder in patient management, and also it can cause a problem while getting fitness for anesthesia, and therefore diabetes mellitus, hypertension, asthma and tuberculosis have to be asked in the negative history. Moving on, past personal and family history. Now we have to ask for history of prior medical or surgical events, then medications such as antiretroviral therapy, anti-cox therapy, asthma, which the patient would require steroids. Similarly, for dermatological conditions where steroids or immunosuppressants can be used, and most importantly, over-the-counter medication or any other parallel source of medicine or other pathies which the patient is referring to. In that case, it is a good option to have a look at the medications which the patient is taking, so that we can rule out any sort of steroid or immunosuppressant drug use. Moving on, sleep, appetite and bowel and bladder. This is not very important in case of a trauma history, except for bowel and bladder, which is important in case of a spinal trauma. But in case of infective or neoplastic cases which will lead to a prolonged and a chronic catabolism, sleep, appetite and bowel and bladder, also weight loss and loosening of clothes in case of tuberculosis becomes an important finding. Moving on, family history and consanguinity will not be very important in case of an acute trauma case, but in case you have a history of or a case where the child is of a pediatric age group and the patient has some sort of a congenital deformity or a neoplastic etiology, then all these genetic related factors will come into play. So at the end of history, we can get a differential diagnosis, which is a patient of this age and this sex, such as 40-year-old male, with your first line of chief complaints, which means a 40-year-old male who suffered a road traffic accident on this day at this time. Then we quote the significant positive points in the history, such as the patient has a wound which is roughly the size of his palm on the anterior aspect of his thigh and was unable to walk, and you have to broadly specify the anatomic region, which means I suspect in my differential diagnosis at the end of history a fracture around the hip joint. This is all that you can say at the differential diagnosis at the end of history, because as we have spoken earlier, history is collation and rearrangement of data which is given to you by the patient, and it is not your own diagnosis. And because of that, your own diagnosis can be arrived at only after you have finished your examination, and therefore differential diagnosis at the end of history will be a broadly specified anatomic region in colloquial terminology. Moving on, now in every examination you will have a general examination and a systemic examination. General examination is best finished as quickly as possible, assuming that your patient has no major abnormalities in general examination. The first line to start with general examination is patient is conscious and cooperative, sitting or lying comfortably in the bed, oriented to time, place and person. This is the first and most important line, which shows that you are dealing with a stable patient and not an unstable patient. Then the standard pallor, edema, lymphadenopathy, icterus, cyanosis and etc. The 6 points to be examined in medicine. If there is a significant positive, you can mention it. Otherwise, you can mention that no significant findings on general examination. Very important to have temperature, pulse, respiratory rate and blood pressure. This also confirms the fact that you are dealing with a stable patient and not someone who is hemodynamically or neurologically unstable. And if there is any obvious gross observation, there exists a lot of debate as to whether to mention any non-orthopedic gross examination findings in the orthopedic viva or not. In my opinion, it is a good option to mention any gross abnormality. If you find a swelling or if you find some sort of a stigmata of some other disease, it is always a smart option to mention it as a part of your clinical findings. Moving on, local examination. Now, local examination per se is a very large topic, and therefore what we can do is we will discuss the principles of local examination here, and then we will do a separate video on local examination of hip or local examination of knee. And what I will do here is I will just put across the points you have to cover in case of local examination. So first is of course inspection. Inspection, we have to see the attitude of the body, which means how is the patient lying with respect to the vertical axis. So the patient can be lying supine with both his limbs in both his upper and lower limbs in extension, or if one of them is in flexion, you can mention likewise the limb position in terms of flexion, extension and rotations. For example, in majority fractures of the hip, the ipsilateral affected limb will be in a certain degree of external rotation and it may appear shortened. So limb position and gross deformity. Third and most important is if there are any signs of inflammation or infection, such as there could be your redness of the skin, there could be dilated veins, there could be a localized swelling, there could be pus pockets, or there could be a gross swelling of the entire lower limb, which could indicate that there is a lymphadenopathy somewhere proximally in the system. Apart from that, you should look for any other signs such as calor, dolor, rubor or functionalism, which are apparent without touching the patient. Remember, this is all about inspection, which is you are seeing before touching the patient. Now moving on, we have palpation, that is firstly inspectory findings to be confirmed. So the amount of flexion, the amount of extension or the shortening, limb length, range of motion and special tests. This is what will be covered in your palpation section. Now percussion and auscultation is not something which is a part of orthopedic examination, and therefore we can consider that orthopedic examination has inspection, palpation, range of motion and special tests. These are the 4 basic criteria under which your examination findings are coming. At the end of the case, you will have to provide a differential diagnosis at the end of examination. Now, the difference between differential diagnosis at the end of examination and the differential diagnosis at the end of history is that in differential diagnosis at the end of examination, you are free to use your academic words and scientific terminology, and you need not say fracture around the hip or you need not say fracture around the knee. You can talk about distal femur or proximal tibia or intertrochanteric neck femur or intracapsular neck femur. So how do we start? We start by quoting the age and the sex of the patient, as we did in the previous history, that is 40-year-old male, with the line 1 of chief complaints, that is the patient suffered a high energy road traffic accident on this place at this date at this time. Now, significant positive points in history and examination. And now we can use scientific terminology. So we need not say that the limb is swollen and the limb is deformed. We can say that the limb has signs of inflammation, there is edema, and there is 5 centimeter shortening and say 30 degrees of external rotation on the affected limb. So scientific terminology can be used, and then we can narrow down to the specific anatomic region. And so you can say that from my history and examination, my diagnosis for this case is a fracture of the distal femur. So this was our video about the basic case taking format. A huge thank you to Medusane for letting me collaborate with you. This was a very basic starting video, and we will be coming out with more videos in the future. I hope to do a couple of videos on examination and evaluation of specific joints, in which we can go in detail about range of motion and specific tests and limb lengthening and shortening and things like that. So please get in touch with me. My channel is Rapid Revision of Orthopedics by Dr. Prateek Joshi. This is up and live on YouTube, and this particular video is being distributed through Medusane India, which is through their channel. So like and subscribe to both the channels, and please get in touch with me over Facebook or Instagram or WhatsApp. I will be more than happy to help you. Thank you.